A lot is possible when it comes to PAD treatment. Of course, the earlier the diagnosis and treatment, the more options that are available. But a big issue is inconsistencies of diagnosis as well as treatment options from doctor to doctor, facility to facility. Patients just don't know what's possible. That's why we are bringing patients to the table when it comes to discussing the future of PAD. They not only need to be at the forefront of what's new and what's next, but they also need to influence it. In this Patients as Partners discussion that we have coming up here, we are bringing researchers, doctors, and innovators together with patients to discuss the critical gap between what PAD sufferers experience and available solutions. Leading our discussion is Dr. David Armstrong, Professor of Surgery and Director of the Southwestern Academic Limb Salvage Alliance at USC's Keck School of Medicine. Before we bring in the rest of the panel, one thing that's really critical is getting everyone on the same page with best practices. I think that's going to solve, at least one of the big problems that patients face. One doctor amputates, another doctor revascularizes that pedal loop. That's just one of many examples. So Dr. Armstrong, tell us about the effort that you're actually leading in establishing best practices for the sake of saving life and limb.
To speak to your question, I was recruited out here to Los Angeles from Arizona, where I'd practiced for about a decade before, with the big idea of trying to eliminate preventable amputations over our area, about 10 million people in the Southland and of course around the world. That was a few years ago, and I think we can do it. I mean, it's a massive undertaking, but what matters is what you're doing right now, Kim. And what matters is not only physicians and surgeons and nurses and therapists talking to one another, but it's patients at the center of that. Our group, which is called the Southwestern Academic Limb Salvage Alliance, has been working real hard in our region to try to get that out there. As part of that, we formed something called the American Limb Preservation, American Society of, or American Limb Preservation Society, or ALPS, and that just happened now, and that's designed to generate more best practices, not only around the United States, but really around the world. And what we know is that if you put people together that care about this problem, be they a podiatrist, a cardiologist, a vascular surgeon, an endocrinologist, an infectious disease doc, a nurse with an interest in the area, a physical therapist, good things happen. In almost any kind of permutation, there's a reduction in amputation, especially when you make the patient at the center of that. So when we talk about best practices, what we really talk about is getting people in the room, in the clinic, or even virtually that care about that problem. That's the first step.
And our next panelist is actually Dr. Oliver Alame, Clinical Associate Professor of Vascular Surgery at Stanford University, also the founder of VasTrack, which I think, is going to revolutionize exercise therapy for people with PAD in a remote way. Doctor, thank you so much.
Yeah, so thanks for including me today. And my research focuses on clinically validating the sensors in smartphones and smartwatches in patients with peripheral artery disease. And one of the things that I learned early on is that, yes, the technology may be great, but again, the education piece is super important. So what I've done is worked with the Society of Vascular Surgery to kind of come up with an exercise therapy program that's home-based, really to address less the critical limb ischemia phase, but more the earlier kind of patient journey. Once PAD is initially diagnosed and you have claudication, it turns out exercise therapy is incredibly effective, almost as effective as looking at your feet, or maybe as effective. That was an interesting number, Dr. Armstrong. I didn't know that, which is great. But we're working together to just develop a home-based exercise therapy program to really make sure that that is the exercise component is addressed and utilized.
Thank you. We can't wait to see VasTrack in everybody's hands. Our next panelist is another vascular specialist from Canada, Dr. Charles Demestral. He's a vascular surgeon at St. Michael's Hospital, also assistant professor at the University of Toronto. Can you tell us about what keeps you up at night? What's your primary focus when it comes to saving life and limb, doctor?
So as you said, I'm a vascular surgeon at an inner city hospital, and we have a toe and flow modeled limb preservation team. But I'm also a scientist and spend about 70% of my time doing research using big data that we have in our universal public healthcare system to look at the patient trajectory and particularly disparities in prevention efforts and the effectiveness of prevention efforts at a population level. And to answer your question, what keeps me up at night is patients' access to expert limb preservation teams with the skill set that we've just been seeing. But upstream from that also, looking at the access of patients to foot screening by their family doctors or podiatrists. And then even further up from that, patients' understanding of potential risks for foot complications from diabetes.
And I want to introduce Monique. She is from Alberta, Canada. She's an incredible friend to all of our other friends online and all of our support groups. She has walked her way out of CLI already once, and she has been struggling with this next set-in of severe lifestyle limiting claudication, including rest pain, and her vascular surgeons pretty much written her off. But second, third, and fourth opinions just aren't as available, maybe in Canada versus the US. And we've had US doctors in previous conferences who have looked at her angiogram, her latest angiogram, and they said, oh my gosh, we can get that blockage that's in the SFA. Why won't anyone treat it? So she's left to suffer, and I know the rules are different, but I wanted her to share a little bit of her journey and where she's at right now. Monique, thank you so much. We really appreciate you being a voice for so many.
My first sign of peripheral artery disease was probably on my elliptical. My foot was going numb. And I went to the doctor and she pretty much said, oh, it's just a pressure point. I mean, I was diagnosed finally in March of 2017.
Right, you had a CT angio, right?
I've had CT angios. They can see that I have almost like nothing there for my femoral. They can see all my collaterals. They can see that, I don't have much in my lower legs.
Mm.
And because of that, they won't treat me because of my lower leg.
So I've had the opportunity to look at your CT angiogram, and you do have a long segment, sort of subtotal occlusion of the left superficial femoral artery with heavy collaterals. And you have relatively preserved outflow in the tibial vessels, but you clearly have problems with your inflow in the left leg. And if you have a disease like that, even here, if somebody has, intermittent claudication, then you would treat that disease medically as long as you can. But if you're going into the realm of rest claudication, and I think at some point your ABIs were down to less than 0.5, and you were on, decent medical therapy, you could make an argument to intervene on that. So is there like a treatment algorithm up in Canada?
On average in Canada, the approach, first thing to say is, there are 10 provinces and each province has its own healthcare system. But within the healthcare system, you'd think, well, it's universal healthcare. It must be more like the UK with clear guidelines from an
the NHS.
Ministry of Health on how to manage certain things. Yeah, so it's very different from the NHS. We don't have guidelines that we have to stick to, and I think people's practices are very variable. That being said, on average, I would say most vascular surgeons in Canada with respect to claudication are probably more conservative than in the US. But I think, I haven't seen the angiograms or whatnot, but certainly the mainstay of therapy would be medical management and walking. But if you're progressing towards limb-threatening ischemia with rest pain, or if you have really debilitating claudication and it sounds like you've tried exercise and are doing all that's possible, certainly revascularization, depending on the extent of the disease, is considered by most Canadian vascular surgeons.
So the one that I saw, he's like, at first he's telling me, oh, I need bypass. My veins are no good. He'd have to use my arms to do bypass. But then as I walked and made my circulation better, then he said he wasn't going to touch me.
Right.
But now
So-
you're sitting there at night, and I see you posting, you know,
Oh, I
online where
know.
you're talking about waking up in the middle of the night and having to dangle your feet off the side of your bed because you're in so much pain, and that's the only relief, if at all, that you can find in the middle of the night. And yet
Yeah.
you did also go see an interventionalist who also referred you
did.
back. So I feel
He
like
just he just told me that Canada is more conservative, that he can't revascularize my legs.
If you have breast pain, you deserve some sort of more intervention. That's all I wanted to say, that we're seeing a progression of disease here. So something changed, or, you know, maybe you need to be reevaluated to see if your SFA disease has extended into the popliteal artery. That's usually the case. Once you get some blockage below the knee, it can lead to rest pain if everything above is fine.
Blockages, yeah.
Okay.
Now, this is an evolving disease in terms of symptoms. And when something changes, you need to, as you've done, bring it up with your family doctor and your specialist. And even though somebody may have said in the past there's nothing to do, that may not be true anymore when the symptoms get more severe.
I don't know. It seems like nobody cares. It's like, you know, and it's not like I'm not the patient that's going in there and saying, you know, just whatever you do is okay. I'm telling them, I'm asking them about certain procedures, and they're not, you know, they're saying, well, no, Canada's more conservative. We don't do that here or whatever. And I don't know how much is dictated by the government or what is or what isn't, right?
You have lifestyle limiting claudication. This is like lifestyle. This is like angina in your legs, you know, and this is the way to describe it. I'm sure that I think the doctors were heartened by your perseverance and your exercise and your progress with the numbers that improved, which is already.
The first question I asked my vasculars is, can I still work out or will I die?
Yeah, but just because you're making a little bit of progress, well, it's actually a lot of progress in terms of your numbers, doesn't mean that you don't have lifestyle limiting claudication, and that's what really has to be described to folks. And I think maybe sometimes in a 10-minute or a 15-minute visit, that may not get communicated. Sometimes the doctor, he or she, might just look at those numbers and say, "Oh man, this is awesome," and she's exercising. Look at this. I mean, and to Oliver's point, exercise works for a lot of people. And the best surgery, by the way, is often the one that we never had to do. But in your case, that may not be the case.
Dr. DeMastro, what are some of the changes that we can look forward to? I know that you're committed, which is why we got in touch, because you are committed up there to saving life and limb. What advances are you seeing?
What I'm trying to do, and what many of us, including people like Ahmed Casey, I think Dr. Armstrong knows well, and Karen Cross, who's an amazing plastic surgeon working on the diagnostics. I mean, this is just in Toronto. We have an amazing team. Calgary's got a great team as well. But these teams are popping up across the country, you know, inspired by Dr. Armstrong and others. And what we need to do is build the evidence basis to show our, you know, health administrators that this is worth investing in. And it's such a no-brainer that you take the money that you're spending on amputations and you put it in prevention, and you save money, and it's obviously in the patient's best interest. But you know, we need data to really prove that, and we need Canadian data, and that's kind of my little part in this area.
And I think it'd be great to have patients at the table of discussions of the future of pad care in Canada as it is in the US. And so I'm happy to connect you both, because I think that Monique is one of those poster children that literally does everything right, and she still can't get the ear of a doctor, and she has a lot to say. And there's a lot that I think physicians can really learn from her experience, and she's willing to teach and participate in the future of care in Canada.
Kim, I'm sorry to interrupt, maybe you can kind of accelerate some of this. I don't know if we're violating some kind of HIPAA or confidentiality transnationally, but maybe you can send this recording ahead to some of the folks in Calgary, maybe to kind of accelerate stuff so they can get a good listen, you know? What do you think? I mean, I don't know. Anyway,
I'm happy.
You know what? I'm going to do it. So there we go. I'm going to send an email with your permission, Monique.
Yes.
I'm sending an email right now. All right. That's great. Carry on, please.
Thank you. No, we appreciate, you are such an amazing patient advocate, Dr. Armstrong. We appreciate you so much. Thank you so much, Monique. We really appreciate you sharing your story. You are such a strong woman, and for your participation, I'm going to be sending you this amazing book, Creating Life Balance.
I just got an email back. I copied you in here from that center in Calgary back to you, and they're welcoming Monique there, FYI. So that was quick service for you there, Kim.
Monique, oh my goodness,
yeah,
Monique.
Okay, yeah,
excellent,
so
David. That's all work.
Yeah,
I am literally going to cry right now.
Wow, this is what it's all about.